Now it's time to talk instruments. The instrumentation used in plastics is much like that used in general surgery, with a couple new pieces. In plastics, surgeons like to use instruments that are fine-tipped and precise, but they're also universal. So think mosquitoes, iris scissors, small needle holders, single-toothed Adson pickups. If you're ever in a situation where they want a mosquito and you've got several to choose from, be ready with the one that has the finest tips. Make sure you do this during your setup so you're not scrutinizing the tips when they're asking for a tool. Some new instruments include rhytidectomy scissors, liposuction cannulas, dermatome, mesher, endobrow instruments, areola markers. Many of these instruments are pictured in your instrument book beginning on page 164. Make sure you indicate these specific instruments on your SPRs where appropriate. In regards to plastic surgery equipment, you'll see some new ones. There's a fair amount of laser technology used in plastics for skin resurfacing, and the CO2 laser is used for that. Also, in liposuction cases, you'll need a liposuction machine and the large bore suction tubing that sucks out the fat. Your world of implants will be broadened greatly, and you'll see implants you never knew existed. Generally speaking, if an implant is going into a soft tissue region, you can count on the tissue to be undermined to allow a space to put the implant. If the implant is being used to enhance a bony structure, like a chin implant, you can expect the surgeon will want to secure it to a bony structure with screws to keep it from migrating postoperatively. One supply you must always have at the ready and have backups in the room for if it dries out or gets dropped is a marking pen and ruler. Always, always, always have a marking pen ready. And another non-book Gen Cane specific rule is to never give a plastic surgeon an already used blade. Every cut they make gets a brand new knife blade. People are paying a high price for a great cosmetic outcome. Start them off right with a smooth incision with a sharp knife. On this slide, you see a dermatome and a graft knife. Look at them in your instrument book too. The dermatome is like a lawnmower for skin, and the depth of dermis it harvests is selected by the surgeon. Remember, this is the instrument of choice for a split thickness skin graft, which does not take the entire dermis. As the surgical technologist on the field, you will want to ensure that the dermatome does not snag on the skin's surface, so be prepared with the surgeon's preferred lubricant. Many of them use mineral oil or lidocaine jelly, and have the safety engaged when it is not in use. The graft knife is also used for split thickness skin grafts, but it is the handheld version. Remember that for both of these instruments, the depth of harvest will be selected by the surgeon. Next is a mesher. This instrument is crucial to the success of the split thickness graft, as the surgeon will push a piece of harvested skin through the mesher and it will create holes in the graft, and this is known as aeration. This technique serves multiple purposes, including expanding the size of the graft to cover a larger surface area with less tissue, and also prevents blood and serum from accumulating during the healing process, which could lead to compromised healing or even skin graft tissue rejection. Mwah, mwah, mwah. Tissue rejection is a major complication in this branch of surgery, and the operative team takes all the precautionary steps possible to prevent that from happening. The final instrument we'll discuss today is the pneumatic power drill. You met it in orthopedics, it showed up again in oral maxillofacial, and it's back for more. This drill is used to model bony tissue by way of a burr. It creates anchor holes for wires or screws, and it's also used to cut through bone with an oscillating saw blade. It is not uncommon for plastic surgeons to complete fellowships in hand surgery during their training. Hand procedures are delicate and meticulous, but so are plastic surgeons, so it's naturally a good fit. Obviously, orthopedic surgeons can also operate on hands, as can neurosurgeons. That's why when trying to decipher what type of specialty you're doing, it's safe to say that if you're working with bones and their function, it's orthopedic. If you're dealing with nerves and their function, it's neuro. You'll experience both in plastics. You're welcome. Our final topic for one-sided conversation will cover the many varieties of burns. As you can see by your slide, there are 3 categories, 2 of which share the same level of degree. The first thing you need to know is that burns are classified based on the depth of tissue affected. In first degree, superficial burns, only the outermost layer of epidermis is injured. The skin appears pink or red. It's dry and painful to the touch. Doesn't that sound like a sunburn? It should, because that's exactly what a sunburn is. The next level of injury occurs when varying degrees of dermis are injured. The skin will appear blistered, red, and moist. Upon the injury of the epidermis and the entire dermis, a full thickness second-degree burn is diagnosed. It will appear white and smooth, with a shiny surface with dry blisters and edema. The worst type of burn is a full thickness third-degree burn, whereby the skin, subcutaneous tissue, muscle, and underlying bones can be burned. Third-degree burns are often centered in an area of second-degree injury. Skin burned to this level may appear white, brown, black, and it's going to probably be waxy. Third-degree burns develop eschar, which is devitalized, non-elastic tissue that adheres to the wound site. This is very important to know, as eschar can lead to constriction because of its non-elasticity. Constriction can lead to further tissue death, such as if eschar is developing circumferentially around the arm. It acts like a tourniquet that can't be taken off. Understanding these varying degrees of burns can help you understand why a third-degree burn patient often does not immediately suffer from pain associated with their third-degree burn. All of the nerves have been injured or destroyed by the burn. In circumstances when the nerve tissue is not completely destroyed, it may attempt to heal itself. It is during this time that their sensation of pain will increase greatly as the peripheral nerves begin sending their impulses back to the central nervous system. Your next slide shows the varying levels of burns on the palm of a patient. Notice how the third-degree burns are not all third-degree, but are instead within regions of second-degree burns. This is common unless the tissue is truly, completely destroyed. You received a handout with your PowerPoints that shows you how to determine the percentage of body surface that has been burned, based on what part of the body is burned. Notice that the entire head makes up 9% of your body's surface area, while our torso makes up 36%. Our arms make up 18%, the groin makes up 1%, and your legs make up the remaining 36%. These values are figured with anterior and posterior surface areas added together. Just like draping the plastic surgery patient will require consideration of the body parts involved in the procedure, determining the extensiveness of a burn requires you to consider the body parts involved and the rule of nines to figure out the percentage. That concludes the video lectures for plastic and reconstructive surgery. I'll see you soon.